to welcome everyone to this joint crosstalks. What have we learned about child mental health during the pandemic? The Leong Center is co-hosting this with the SickKids Department of Psychiatry and the Center for Brain and Mental Health. Next slide, please. Before we start, I just wanted to acknowledge the land that we live on, but with a bit of a personal note. So as many of you know, Toronto, where most of us are, and where SickKids is, the word Toronto is from the Mohawk word Takaranto, which is place in the water where the trees are standing. And we are blessed with, many trees in Takaranto and surrounding us. And these are two serviceberry trees in my yard. I reflect, as part of a journey around reconciliation, trying to learn more about First Nations and other Indigenous practices. And I would say, the connection between Indigenous ways of being with land and well-being are very important. And I think I've, learned a lot about that. And certainly now with spring coming, just reflecting on, the importance for me, at least, of being in nature. But I also reflect on, as healthcare providers, long before there were settlers here, there were sophisticated Indigenous healing and practices, which included medicine, often from out of nature. So the serviceberry trees that you see, both the berries and the bark, are have been used for a number of medicinal properties. And I like to reflect on that a little bit as I reflect on the gratitude of living here as a settler. So for thousands of years, Takaranto has been the traditional land of the Huron-Wendat, the Petun First Nations, the Seneca, and more recently the Mississaugas of the Credit. Today, Takaranto is home to many Indigenous people from across Turtle Island, and we at SickKids are certainly committed to trying to do what we can to reconcile our relationships and build trust with all of the different Indigenous peoples living in Takaranto and more widely Turtle Island. So with that, there were long bios in this. I'll talk just briefly to say this is a crosstalks format. So we have 4 short talks, about 8 minutes each, followed by a discussion that will be moderated by Eyal. Please submit any questions in the Q&A chat as we go, and we'll try our best to have them answered by the panelists. So I'm really delighted to welcome the panelists. Again, just I won't go through their full bios, but Jala Rizeq is a Kimel family fellow in the Center for Brain and Mental Health. Next is Katherine Cost, who's a research associate in the Department of Psychiatry, who came to SickKids from following a Ph.D. in Neuroscience at Tulane and postdoc at U.T. Natasha Saunders is a staff pediatrician and clinician-investigator in the Division of Pediatric Medicine and an assistant professor at IHPME at U of T and an adjunct scientist at ICES. And Alain Tulane is a pediatrician in the Division of Adolescent Medicine, also an assistant professor at the U of T, and also affiliated as a fellow with ICES. And then finally, Tricia Williams is a clinical neuropsychologist at SickKids who leads the neonatal neuropsychological services for assessment and consultation for children and families. And we're really delighted to have all of them here to speak to us about their work on mental health in children and adolescents during the pandemic. So with that, I will pass it on to the first speakers, Jala and Katherine.
Good morning. Thank you for attending today's session. I'm Katherine Tombeau, and I'll be presenting the first half of our talk. And then my wonderful colleague, Jala Rizeq, will be presenting the second half of our talk on the COVID trifecta, economic challenges, stress, and mental health. Next slide, please. First, we have no conflicts to disclose. Next slide. So this all started a little over a year ago when 4 longitudinal cohorts, including 2 clinical cohorts, POND and SickKids Psychiatry, and 2 community cohorts, Spit for Science and Target Kids, began this amazing collaboration. Our goal was to improve the understanding of mental health and well-being of children, parents, and families during the COVID-19 pandemic. Next slide. Our first analyses included approximately 1,000 participants with children ranging in age from 2 to 18 years. Of particular interest, just over 60% of children had a pre-existing psychiatric diagnosis, and 4.2% had COVID exposure, either themselves or a family member. Next slide. Our first objective was to determine the rates of deterioration and improvement in the mental health of children during the first wave across 6 domains of mental health, including depression, anxiety, inattention, hyperactivity, irritability, and obsessive compulsive disorder. Across all 6 mental health domains, both younger children and older children experienced deterioration in at least one domain at around the same rate, 67 to 70%. Some children, however, did experience improvement. About 31% of younger children, but only 19% of older children experienced improvement in at least one mental health domain during the first wave. Next slide, please. Our second objective was to determine what factors might be associated with deterioration and improvement in mental health, including COVID-specific variables, for example, stress associated with social isolation and COVID economic concerns, as well as individual level variables, for example, pre-existing psychiatric diagnosis for a child. Stress from social isolation had a huge impact. Greater stress from social isolation had the strongest association with deterioration in all mental health domains. In a nutshell, public health measures that result in social isolation are associated with deterioration of mental health in children. A pre-existing psychiatric diagnosis was sometimes associated with improvement, but was more often and more strongly associated with deterioration. Take-home message here, children with pre-existing psychiatric diagnoses may require more support to manage the mental health impacts of the pandemic. Lastly, the results on COVID economic concerns gave us some pause. In the smaller group that did experience some improvement, greater COVID economic concerns were associated with improvement in 3 of 6 domains, and less often and less strongly associated with deterioration in only 1 domain. The take-home message here is that while greater COVID economic concerns are paradoxically associated with improvement in this small sample in several domains, this is potentially due to less work-life conflict and the provision of government programs, including CERB. Understanding the nuanced interplay of economic concerns and mental health during COVID will require further quantitative and, importantly, qualitative studies. So thank you for your time and attention. I'll now turn the floor over to my colleague, Jala Rizeq.
Thank you, Katherine. Next slide, please. I will now shift to another major goal of this project, which was to quantify the extent to which families experienced material and economic deprivation due to COVID-19 restrictions specifically, including such things as housing and food insecurity, job and income loss. You can see the impact was substantial in this sample, with 35% reporting moderate to extreme worries about financial instability, 27.7% reporting concerns about living situation instability, almost 10% reporting food insecurity, with 12% reporting job loss. 24% reported reduced ability to earn money. With this estimate in mind, we wanted to first identify what makes certain families more susceptible to deprivation than others based on pre-existing or pre-COVID factors. Next slide, please. Next slide, please. I'm not seeing the next slide. Oh, great, thank you. Oh, the one before. There you go, thank you. So I used data from 2 time points collected between May and November of 2020. I identified 3 pre-COVID risk or vulnerability factors that impact material deprivation. A child with a pre-existing mental health condition, lower socioeconomic status of the family as measured by household income and parental education, and being of a non-European ethnicity, all significantly predicted higher material deprivation due to COVID-19 restrictions. The presence of a mental health condition and lower socioeconomic status were relatively stronger predictors than ethnicity. With that in mind, we then wanted to see the impact of this specific deprivation on stress and mental health within families over time during COVID-19. Next slide, please. We found that higher material deprivation is associated with higher parent stress and parent and child mental health symptoms at time 1 during COVID-19. Those 3 then predicted higher parent stress and both child and parent mental health symptoms at time 2. So we see the impact over time. Importantly, we find cross-legged associations with parent and child mental health having reciprocal effects on each other over time. Similarly, there is a reciprocal association between mental health symptoms and parent stress, with a stronger path from parent and child mental health to parent stress. Next slide, please. Based on these findings, there are 3 broad and clear implications. First, we need to ensure there is material and financial assistance generally, but especially at times of crises, and particularly for the most vulnerable in our community, in order to buffer the impact on material deprivation and its negative sequelae. Second, it will be important to continue to invest in mental health services for both children and their parents, considering their reciprocal effects over time. It is also important because it could potentially buffer the impact of public disruption and crises on perceived stress over time, improving tolerance of stressful circumstance. Finally, as researchers and clinicians, finding creative ways to reduce stress due to social isolation and restrictions while adhering to public guidelines is also an important factor, as it still has an impact on children and parents' mental health over time. Next slide, please. So to conclude, we would like to thank our research team, the families who contributed to this study, and our funders, and thank you to all of you for listening today.
Thank you very much, Jala and Katherine. And now we will move to the next speaker, Natasha Saunders.
I'm delighted to have the opportunity to present to you some of the work our team has been doing on virtual mental health care for children and youth through the pandemic. As you've heard, there's been widespread concern about the mental health consequences of the COVID-19 pandemic. Social isolation, school closures, financial strain, and the stress of possible infection are all risk factors for mental illness and addiction. You've all probably seen at least some of the headlines speaking about the deterioration of the mental health of children and adolescents through the pandemic. But how much of this is translated into an actual change in healthcare utilization is not known. With the pandemic onset, there was an unprecedented transformation in healthcare delivery with the rapid adoption and restructuring of virtual care by healthcare providers and organizations, made possible by virtual care platforms, digital health innovations, and virtual care reimbursement models. Mental health care delivery is well suited for virtual care, especially for children and youth who may be well accustomed to technology. And studies on the effectiveness of telepsychiatry demonstrate equivalent outcomes across diverse mental health conditions in patient satisfaction, adherence, and symptom reduction. But uptake of virtual care among children and youth with continuous or new mental health care needs during the COVID pandemic is not known. So our objectives were to compare rates of acute and ambulatory mental health care and the extent of uptake of virtual mental health care in children and adolescents before and after the onset of the COVID-19 pandemic. Next slide. We performed a population-based repeated cross-sectional study of all children and adolescents ages 3 to 17 years in Ontario using linked health and administrative datasets available at ICES. And our data spanned from January 2017 to the end of November 2020. Next slide. For this work and the work that Dr. Tulane will show shortly, we modeled the trend in pre-COVID weekly visits since January 2017 and then computed the expected post-COVID weekly visit rates. We then compared the observed and expected visit rates, and then we described the proportion of virtual visits. Next slide. Before showing you the data, it's important to highlight what these data do and do not show. We show physician and hospital-based healthcare utilization through the first 9 months following the pandemic onset. What our data do not show are levels of need and levels of distress, as well as community mental health supports, for example, social worker and psychologist supports who provide a large volume of mental health care for children. So this slide shows emergency department visits and hospitalizations before and after the pandemic. The table on the right-hand side shows you the relative rates of observed and expected visits. And throughout the next series of graphs I show you, the solid line represents observed visits and the dotted line represents expected visits. And as you can see in the dark blue, which represents emergency department visits, and the light blue, which is hospitalizations, there was a rapid and immediate decline to about 40% of expected in visit rates at the pandemic onset. Both showed some recovery in the summer. However, as of the end of November, visit rates remained well below expected levels at around 80% of expected. This has not been the SickKids nor my anecdotal experience, but represents what's been happening provincially. Next slide. So this next slide shows ambulatory mental health care visits. The red line shows in-person visits, and the green line shows virtual visits. And what you can see is a very rapid adoption of virtual care, representing about 90% of care. The overall visit rate in dark blue declined immediately following the pandemic onset and reached expected levels by about July, with an 8 to 10% increase above expected levels over the last few study months. Next slide. So this slide shows the outpatient visits by age, and the purple line represents adolescents and the dark blue line represents school-age children. And both groups show a rapid decline in utilization among adolescents. By July, visit rates were slightly above expected levels, whereas school-age children had rates that were at expected levels. Next slide, please. And this slide shows the proportion of virtual visits following the onset of the pandemic. And as you can see, both age groups rapidly adopted virtual care to about 90%, but both groups also had a significant tapering of virtual care use to around 70 to 75%. And this was more pronounced among younger children, whereas among adolescents, virtual care was a little bit more sustained. Next slide. So this shows visit rates by sex. And as you can see, females in red, rates initially dropped, but then surpassed expected levels in July. In males, depicted in dark blue, rates initially dropped and matched expected levels from July onwards. Next slide. For virtual care, both males and females had a relatively similar pattern of virtual care utilization, starting at around 90% and tapering to around 70% through the latter months of the study. Next slide. So the next two slides show mental health outpatient visits by diagnostic grouping. So for mood and anxiety disorders, the top graph, there was initially a drop and a resurgence above expected levels by July. For other visits, which represent neurodevelopmental concerns or ADHD, for example, these visits initially dropped, but since the summer have been at expected levels. Next slide. For psychosis, visits remained above expected levels throughout the entire pandemic, as have substance use disorders, which have almost doubled throughout the entire pandemic. Social problems, so for example, family discord or educational concerns, dropped initially at the onset of the pandemic and are approximately at expected levels. Next slide. This slide shows the proportion of virtual visits by diagnostic grouping. Again, you can see a large adoption of virtual care with 85 to 90% adopting virtual care across all diagnostic groupings. But the visits done virtually were not sustained over time for all groups. There was a greater drop-off in those for neurodevelopmental or other concerns, as well as social concerns compared to those for mood, psychosis, and substance use disorder, which were maintained at about 75 to 80% of expected levels. Next slide. So the key findings of this study were that there was a very large and rapid decline in acute care visits with a partial return towards, but not at pre-pandemic levels by the end of November 2020. There was an initial decline in ambulatory care with a return to expected levels for males and 3 to 12-year-olds, but by July, and above expected levels for females and adolescents. There was a large 90% initial shift to virtual care that was not completely sustained and currently sits at about 70% of mental health care delivery. We saw a large and notable increase, almost doubling in visits for substance use disorder. And virtual care was most often used for substance, mood, and psychotic disorders. Some important implications of our findings are that we've shown a rapid drop-off in the mental health care utilization with a marginal increase in ambulatory care. And the level of need that we are hearing about in the community may be much greater than what we're actually seeing in terms of healthcare utilization. Can you go back to the slide, sorry? While telepsychiatry maybe has been shown to be effective for in small numbers for many disease groupings, the effectiveness for all disease groupings on such a wide scale and in such a large population is not known and remains to be studied. Virtual care may have made mental health care more accessible for some, but we do not know what proportion are actually new to care, versus if this has created a situation of more visits for the same individuals, and work is underway by our group to explore this further. The other really important piece is that we don't know whether or not this massive shift to virtual care has widened health inequities, making care further inaccessible for some. And Dr. Tulane will speak to this in the next presentation. Next slide. So I'd like to thank the Ministry of Health and CIHR for funding this work, as well as Dr. Tulane, my co-PI, and my large team of mental health researchers and knowledge users. Thank you.
Thank you very much, Natasha, and we'll pass it on to Ellen.
Great, thank you, Astrid and Natasha. So good morning, everyone. I'm really excited to be here virtually with all of you presenting today on COVID-19 and health inequities, specifically asking the question, do virtual mental health care visits risk leaving some children and adolescents behind? Next slide, please. So I have 8 minutes to achieve these two objectives, and I think we can do it. So the first is that we're going to discuss how the rapid shift to expanded virtual mental health care risks creating barriers for some patients. And we're really excited to share with you some of our early findings on the association of health inequities and virtual mental health care uptake among children and adolescents in Ontario during the COVID-19 pandemic. Next slide, please. The implications of health inequities are well known to all of us. They are associated with significant costs to individuals, to families, and to society. This slide shows the vicious cycle that is currently being played out during the pandemic with respect to individuals' mental health. Unfortunately, the risk of experiencing mental illness is not equally distributed across our society. Those who face the greatest disadvantages in life also face the greatest risk to their mental health. And the distribution of infections and deaths during the pandemic, as well as the longer-term socioeconomic impact, are likely to intensify the inequalities that contribute toward the increased prevalence and unequal distribution of mental illness. Next slide, please. So we know that virtual care is an effective method of mental health care delivery. And as Natasha has just described, we have seen a rapid and substantial uptake of virtual mental health care among children and adolescents during the pandemic. While some barriers may be removed, things like geographical barriers, securing time off work, having to organize childcare, paying for transportation or parking, there are considerable barriers that are introduced with the use of virtual care. And the top 3 listed here on the right are the ones that usually come to mind. Things like having reliable and fast speed internet, access to the devices, and digital literacy, which reflects the ability of patients to navigate the virtual platform and effectively engage with us online. However, there are more hidden or subtle barriers, things like having a private or confidential space. This is so crucial for sensitive discussions, especially among teenagers. There's also increased distance between the provider and the patient online, which can make it really difficult to read those important nonverbal cues. This is particularly challenging when we are caring for patients and families who do not speak the same language as us or who have different cultural expectations of care. Next slide, please. So our research team was interested in better understanding these barriers to accessing mental health care. We embarked on a study which aimed to compare virtual and in-person mental health care utilization among children and adolescents in Ontario before and during the pandemic, and examine the impact of health disparities on virtual mental health care uptake, specifically related to rurality, material deprivation, and immigration status. Next slide, please. So Natasha has already done the hard work describing our research methods in her presentation just now, so we can skip the slide and jump right into our findings, which are hot off the press. So this slide shows pediatric mental health outpatient visits by rurality. So I'd like to start by orienting you. So for this graph and all subsequent graphs that I'm going to be showing, the y-axis represents weekly visit rates per 1,000 population, and the x-axis is months over time. So we examined pre-COVID trends for 3 years, starting in January 2017, and post-COVID trends up until November 2020. So the observed mental health visit rates for those living in rural settings are represented here by the red solid line, and those in urban settings by the navy solid line. Expected rates are represented by the dotted lines, and the green shows the observed virtual visit rates. So overall, you can see that mental health visit rates were lower than expected immediately following the onset of the pandemic for those living in both rural and urban settings. This pattern shifted, however, in approximately late July, when observed rates increased.
I think we have lost Ellen. Let's see. I will text her. Before we got on, we were all talking about the different things that we've experienced with Zoom conferences and Zoom presentations. I wonder if this will make us all more flexible people and less perfectionist when we get out of this. Oh, let me see. Oh, there you are. Ellen?
Yes, hi, can you hear me?
Yeah, perfect.
Okay, 1 second, thank you. Okay, so Astrid, can you just tell me where I cut off?
You were just describing the, you were on this slide and just describing the differences. I think you hadn't gotten to the virtual.
Okay, okay. So what we'll do is we'll go to the next slide. So that's, okay, great. Thank you. So this graph shows us the proportion of mental health visits which were conducted virtually following the onset of the pandemic by rurality. And you can see that the pattern observed are very similar, with about 90% of mental health visits being virtual early in the pandemic, compared with about 70% from August onwards for both those living in urban and rural settings. Next slide, please. This graph shows pediatric mental health outpatient visits by material deprivation. This variable is closely connected to poverty and the ability of individuals and communities to access and attain basic material needs. The indicators included in this dimension measure income, quality of housing, education attainment, and family structure characteristics. So the top graph represents the least deprived, or quintile 1, and the bottom is the most deprived, or quintile 5. So if we focus first on the most deprived in red, you can see that the observed mental health visit rates were lower than expected following the onset of the pandemic. And interestingly, this difference was more pronounced in the most deprived group than in the least deprived. And you can also see that following July 2020, observed mental health visit rates for the most deprived closely matched expected rates. However, for the least deprived, this was not the case. Visit rates during the same time period were actually greater than expected. Next slide, please. We also saw variability in the proportion of visits which were virtual by material deprivation quintile. The most deprived, represented here in green, had a consistently lower proportion of virtual visits throughout the first 9 months of the pandemic. In the fall, you can see that about 60 to 65% of visits were virtual among the most deprived, compared with 70 to 75% among the least deprived. Next slide, please. And lastly, we examined pediatric mental health outpatient visits by immigration status. So non-immigrants or those born in Canada are represented by the light blue line, refugees are in red, and immigrants are in navy. So for all groups, observed mental health visit rates, again, were lower than expected from March until June 2020. And this was most pronounced among refugees. Visit rates then shifted to higher than expected levels in July for immigrants and non-immigrants, but not for refugees. Next slide, please. And here we have the proportion of virtual visits by immigration status. So you can see that the percent of virtual visits for refugees ranged from a high of just over 80% in May 2020 to a low of about 55% at the end of August. And for immigrants and non-immigrants, the proportion of virtual visits was similar and at about 90% early in the spring, but this has not been sustained as we saw during Natasha's presentation. Next slide, please. So our key findings are that existing health inequities like poverty and immigration status can lead to disparities in mental health outcomes. And the pandemic has added another dimension to this complex relationship. And despite the substantial increases in virtual mental health care during the pandemic, access is disproportionately limited among refugees and those with high material deprivation. And interestingly, we have not seen any geographical differences in virtual care uptake during the first 9 months of the pandemic. Next slide, please. So what does all this mean? As healthcare providers, we need to better understand the reasons why this is happening and work to address these factors to prevent intervention-generated or perpetuated inequity. We want our interventions, such as virtual healthcare, to be equally available to all. And at a provider, as well as a health systems level, we need to consider how we might remove these barriers that patients face in accessing virtual healthcare. Next slide, please. And we do this by either providing resources to mitigate the existing differences or removing the barriers themselves in order to promote sustained positive change over time. So examples might include things like screening to assess the ability of young people and their families in engaging in a virtual visit, working with community organizations to ensure access to appropriate technology, partnering with local libraries and community centers to provide spaces for confidential visits and printing any necessary documents, providing basic instructions that are available in multiple languages on how to use virtual care platforms, ensuring availability of translator services online, and lastly, advocating for benefit programs to subsidize the added costs associated with virtual care, especially for those families with children with complex and chronic healthcare needs. Next slide, please. Our project is funded by funding from the Ontario Ministry of Health and CIHR, and this work would not have been possible without our expert team listed here in alphabetical order. You can see that the list includes scientists, clinicians, policymakers, and leaders in the child and youth mental health sector across Ontario and Canada. We are incredibly grateful to everyone who has supported us in this work. Thank you.
Thanks very much, Ellen. And I'll pass it on to the last speaker, Tricia Williams.
Good morning, everyone, and thank you so much for inviting me to be part of this really important panel today. I'm here representing an incredible, brilliant team of individuals who have worked tirelessly over the last year to support children's mental health through supporting parents. Next slide, please. And today I'm going to be talking about our program, Interact North. If you remember one thing from my time today, it is who the program is for and how it can help our children and families. The program is for parents. The program is for parents who have concerns about their child's behavior or emotion regulation, who are reporting parenting stress, and who are interested in learning and getting support in building and expanding their parenting toolbox. We've been delivering this program virtually since 2018. And today I'm going to reflect for you on the lessons we've learned specifically during COVID-19 implementation and how they've directed important adaptations to our program. Next slide, please. It's very important for the audience to understand that the iInteract North program is predicated on many years of patient-oriented research designed projects in which we had parent partners sit with us at the table and really get a better understanding of what their needs were. We worked with children and families from the neonatal neurology group, children with early neonatal conditions that often impact later behavior regulation, as well as associated congenital conditions. The needs are outlined here, but many of the barriers that other presenters have noted were so highlighted in terms of access, really inequities in access to mental health support. Unique to our group was also the lack of fit in traditional parenting support that is offered without the contextual understanding of a parent's experience in raising a child with a significant medical or neurological condition. And that led to a really fortunate partnership with Dr. Sherry Wade of Cincinnati Children's Hospital. And Dr. Wade developed the iInteract original program, which was designed for families following traumatic brain injury. It addressed many of the needs our parents were looking for, but also provided that psychoeducation around the impact to brain development of an injury or a neurodevelopmental condition. Next slide, please. That program had been offered virtually for over a decade, and last year, or between 2019 and 20, we completed a pilot on the program. It is 7 sessions that combines online learning with direct parent coaching. It uses many of the strategies in common parenting programs like IHPME or PPP. Importantly, it also involved PCIT, or parent-child interaction therapy approaches. And for those of you unfamiliar, PCIT traditionally in person is delivered when the therapist is behind a one-way mirror, having a bug in the ear for the parent, and giving active coaching and interacting and increasing joy in the family interactions. So the next step to a remote delivery was relatively seamless. Last summer, with the generous support of CBMH and the Leong Center, we were able to extend the program and also build our own here at SickKids, the iInteract North program, in collaboration with About Kids Health, as well as our parent participants, as well as our parent partners, and many community stakeholders. So we're very grateful for that. Next slide, please. So enter 2020. And obviously our team was able to finish our pilot with the remaining participants and then extend recruitment across the hospital without major disruption as the entire world moved to Zoom as a reality. Our lessons in administering this program for our families has led to direct changes and adaptations in our program that I'm going to discuss now. Next slide, please. So this figure highlights our referral and recruitment experience during COVID. As you can see, we've had steady referrals, steady increase in referrals, partly due to our extension beyond neonatal and congenital conditions to target all of neurology, all of psychiatry and psychology, common consumers of mental health support here at SickKids. There's some exceptions to this growth. Initially, as highlighted in March 20, you can see with the shutdown and reduction in in-person clinic visits, there was less referrals. But then as the year goes on, you can see also some interesting trends that had not been observed before in our pilot. Namely, as seen in the shaded red areas, times where families were very interested in the program, but asking to postpone when they would start, or starting the program, getting midway through the 7 sessions that were offered and needing to stop. And I highlight they often happen during that red shaded area when the families were also transitioning to balancing the needs of their child being at home with them and engaging in remote school learning. Next slide, please. In feedback from our parents, from our therapists and our recruitment team, we found the following themes. First, there's some ongoing strengths of the program in its existing format, its flexibility and accessibility. We offer sessions evenings and weekends. There's also the ecological validity that both therapists and parents reflected on in terms of actually practicing the skills and getting direct coaching in their home environment. Unique to our experience during COVID was that we were able to continue offering services at times when other services, mental health services, might have been temporarily disrupted with translation to virtual care. There are many barriers that were identified throughout our year, namely the online fatigue. Our children, our families are spending their entire days now online. So adding another online session is no longer novel and actually can be a burden. And the reality, I think, and what has been highlighted among the other speakers today is just the reality of pandemic burnout and stress. Many of our families are living in survival mode, so our role has also become how to resource and connect families to social resources needed. And finally, and directly informing our next steps, is the guilt and frustration we heard from many families, enjoying the program, seeing its benefits, but really not having the bandwidth to continue or go on to later sessions. In reflection and informing our next steps, our therapist named the importance of the early rapport with our families, and we now have our therapists connected with families, as early as baseline, as well as normalizing and spending time each session to normalize the stress of parents' experience at this time. Next slide, please. And informed by these experiences, our current approach to delivering this service is through a stepped care model. And this is in collaboration with the PON network, as well as our parent partners. So the step care model provides psychoeducation to all families. And this is in the form of a podcast. And I have to give a shout out to our parent advisory board. One of our parents came to us with this idea that this is so much better to them, it's more portable than just referring to read some websites. This is followed by parents based on need into two abbreviated condensed sessions around just general simple strategies about stress management, empathetic listening to the parent or with the parent, as well as strategies that can be easily implemented in the home to increase positivity at a time where everyone's so stressed. And then based on need and parent preference, a collaborative decision is made whether or not they would complete the full program. Next slide, please. So this is my last slide that I really wanted to take a moment to reflect on the importance that we've learned along the whole entire journey, not just COVID, the importance of listening to parents. And this is a poll recently conducted in our parent advisory team meeting last month. And parents, still need that connection that's heard loud and clear. And I guess I want to end my talk today with our team's commitment to continue listening to our parent partners on this journey and to reassure them and our team that our flexibility with this program, our partnerships with parents and the community, and our team's commitment will allow us to continue innovating mental health approaches for families now, but also into the post-COVID future. Next slide, please. And for more information on our program, you can reach us at neurooutcomes@sickkids.ca. And as a reminder, this is for any parents that you may see might benefit from this support at this time. Next slide, please. And this is a huge thanks to our incredible Neurooutcomes Lab and our entire iInteract North team for this incredible year. Thank you.
Thank you, Dr. Williams. I wonder if we can just change the view to see everybody, if that's okay. So we're going to move now to the discussion period, and just a reminder to everybody that you can ask your questions through the Q&A chat box, and we're going to try to do our best to get to everybody's questions. So I'm going to just kick off by some of the questions that have already been put in the chat box. So there's a good one that I'd like to start that I think is relevant to all the talks. So this is a question from Zulfi Buddha. How do your findings compare with the global evidence emerging on mental health in children in COVID-19 settings? What can you tell us about inequities in accessing care and mental health outcomes during this period? So all of you presented data from Ontario or SickKids or Toronto. Would be interested in your thoughts about contextualizing your findings to what we know globally about what's going on with mental health in children in the pandemic. So maybe begin with Katherine and Jala.
Hi, okay. So one of the things that we noticed when we were looking at the literature of what was going on in other countries is that disease prevalence didn't seem to impact the mental health of children as much as, the restrictions that were put in place, the public health measures that were put in place. So what we're seeing is pretty comparable to what we're seeing even in countries that had a very high disease prevalence.
Yeah, and I will add to that just to say that it is very comparable to research that's been coming out from the UK on material deprivation or economic challenges and the associations with increased mental health symptoms as well as stress, which is primarily has been done with adults. So I think our added piece is also including children in this picture, and especially good representation of children with previous psychiatric disorders or diagnoses, which again, I think is a huge strength of the sample and the participants who we've been working with.
Dr. Saunders?
Yeah, so I think when thinking about this issue, I think you have to differentiate between distress and what's happening in terms of distress versus what's happening in terms of actual healthcare utilization, because they're different issues. And a lot of distress may not actually translate into a visit to hospital or a visit to a healthcare provider. And certainly worldwide, we're seeing, increased levels of distress or reported levels of distress. But actually from a population-based standpoint, the only data I found is out of the US. There was a recent JAMA Psychiatry paper looking at emergency room visits for mental health conditions, and they too saw a decline in visits. And so although universally we seem to be seeing increased distress, we're not necessarily seeing that translate into hospital visits. And with respect to your question around inequities, we have in Ontario at least done some work looking at primary care, and we are seeing some similar inequities, with refugee populations not having as many primary care visits for routine immunizations or developmental surveillance as non-refugee populations, as well as some income disparities. So it is being seen in other healthcare settings in Ontario too.
Dr. Tulane?
Yeah, I mean, I agree that patterns are similar globally, which is interesting. I think it's important to think about how these trends and patterns change over time. So we can look at, infectious periods of the pandemic in different areas to see, what might happen or predict what we'll see in our population in terms of mental health needs. I also think at the beginning of the pandemic, we saw everywhere that there may have been some protection. There was potentially people sticking together, and that helping nature may have protected young people and their families.
And Dr. Williams?
Yeah, the only thing I would add to that, I guess, from a direct service perspective for mental health is this, there is a distress, but then there's access. And in the in-between is this sort of acute survival, that this, in a way, accessing mental health is support so needed, but at the same time, we have to recognize it may be more appropriate in terms of psychological first aid, and just because adding another burden to our families is so important. And this has definitely been seen, I think, too, across telepsychology groups that I'm part of that are implementing among at-risk groups across the country.
So the next question is from Sarah Carsley, and is about whether you have a hypothesis to explain the disconnect between the stories in the press. And I think this is alluding to what Natasha presented in particular, and some of the communications that's come out actually a lot from children's hospitals about increased utilization of mental health services during the pandemic, and the data that you presented. How do we get the community mental health data? And I think this is relevant to a few of the presentations. I'll let Natasha Saunders begin, and if anyone else wants to jump in, please feel free.
Sure. So I think there was a few parts to that question, but one was around sort of the disconnect between what's happening, what we're hearing in the media, for example, or what we're feeling versus what the data show. And I think there's a few reasons for that. One is I think there may be a regionalization of care and a shift in potentially children's mental health care being more delivered at children's hospitals to offset some of the increased demand for other non-mental health care at adult hospitals or community hospitals. The other thing is it's really important to look at the denominator. So at SickKids, for example, I don't know the exact numbers, but I think there's about 400 admissions a year. And if that number goes up to 500, that's a 25% increase. And that's the number we're hearing at SickKids. But when you look at a population level, there are about 10,000 hospitalizations for children and youth across the province annually. And so, you know, children's hospitals, though, play a really important role in managing some of the mental health concerns. They are, you know, only about 5% of all mental health beds. And so it's not necessarily reflective of the entire population. So understanding or speaking about the denominator is so important in these situations. And then as far as the community mental health data, you know, I think all of us who do epidemiology in mental health, it's a dream to have those data, but unfortunately, our data systems are not at the level that we would love for them to be to really understand this, but it's really important. And we continue at ICES to work with some of our community partners to try and find ways to get some of those data sets so that we can work together to understand what's going on in the mental health sector. Unfortunately, we're just not quite there yet.
Do any one of the other presenters want to add?
I'll just nod that, you know, we have to remember that there's a lag between the time that we get the data and what we're seeing clinically at the front line. And so all of us are feeling the pressure at different time points. And, you know, the data that we have presented, Natasha and I, are up until November. So I think the story is going to become more rich as we get data coming in. And, you know, it would be lovely if we had it in real time, but this is the best we have right now.
I'm going to move on to the next question, which is a question around the diagnoses that have been captured in some of the studies that were presented today, so the question is, have mental health diagnoses been broken down beyond mood anxiety, alongside the surge in eating disorders? Anecdotally, we are seeing a surge in obsessive compulsive disorder in the community. Is this reflected in research?
Yeah, so the data we use for ambulatory care is based out of OHIP physician billings, and the diagnostic groupings are not fantastic. That's why we have very broad categories of mood and anxiety. We can't really distinguish which is which. There is some better data for psychosis, though, for example. In our hospitalization data, it's not bad, and we do have finer slices of or diagnostic groupings in our hospitalization and emergency room data, because those are based on ICD-10 diagnostic codes, and there's a little bit more space for healthcare records to have multiple diagnoses or formulate a diagnosis. And so in some of the work in the acute care sector that we're seeing, there is data to show a lot of heterogeneity between disease groupings. So for example, eating disorders, it's spot on. Like, we are seeing increases in eating disorders across the province, both for emergency room visits and hospitalizations, but we aren't seeing it universally for other diagnostic groupings, including OCD. And just off the top of my head, I can't remember them all, but I think psychosis is pretty stable. Elena, I'm not sure if you remember off the top of your head all the other diagnoses, but the ones that stood out were eating disorders and substance use disorders were rising, but everything else was pretty flat or declining.
So if I can just add to that,
Go ahead,
while
Dr.
we're not looking at diagnoses, we're looking at symptoms. And when we're looking at deterioration, we looked across these 6 mental health domains in part because the focus was on mood and anxiety. So looking across those 6 domains, the domain where we see the greatest level of deterioration is actually in attention, not in anxiety or mood, but attention. So that was something that was quite interesting to us in our findings. And we did see some uptick in OCD, but not to the level of attention, and as well as irritability.
I'd like to direct the next question to Dr. Williams. It's a question about iInteract. So lots of excitement amongst people who want to participate in it. Do you anticipate families of children with traumatic brain injury who aren't necessarily followed actively in a tertiary care center like SickKids being allowed to participate in the program? If so, when?
That is the goal. That is my personal professional goal, is to have iInteract offered to anyone at SickKids and partnerships in addition to POND. It's currently sitting at it's a clinical research program. But that, I mean, we have done, as you can see, the strategic referral sources. there's often ways to sort of find ways to find the families. And I think TBI is one we have been working on with a partnership with neurosurgery, but also with Holland Bloor Review and their rehabilitation program there. And when in doubt, I just suggest to people who have a family that they may think would benefit to reach out to us, and myself or a coordinator will speak about the referral criteria.
There's some fantastic questions still coming in. I really appreciate it. We'll try to get to as many as we can, though we're running a bit out of time. So question from Karen Leslie about capturing complexity and multimorbidity, substance use and mental health together, mental health, physical health together. How are we gonna unpack those issues? Question for anyone.
I can start there. So Karen, thanks for the question. As you know, this is an area of great interest with the research team at ICES, and we're starting to look deeper at adolescents and young adults specifically. And the next step would be to examine comorbidities. We know that this population is high needs and high priority.
I'm going to change gears a little bit with a bit of a different question. Are there new mental health issues that we haven't, traditionally thought about that are emerging during the pandemic that are providing challenges for healthcare providers in the everyday life, plus the added stress of children doing online schooling?
So I don't think we're seeing this necessarily in the data. In terms of new mental health issues, I think what we are probably seeing more of is things that are not always identified as mental health conditions. So for example, conversion disorder and somatic symptom and related disorders. I think we're seeing a lot more, certainly at SickKids, we're seeing a lot more of that. And we haven't been measuring that specifically in the data, but I think it's something that we have to keep an eye on moving forward, because we don't have right now, we don't have the most robust pathways to get these kids into care, and they often require a lot of healthcare utilization to come to a diagnosis of a mental illness and to be accepting of a diagnosis of a mental illness. And so to develop pathways that are robust and easy to navigate is going to be important moving forward with this population.
And next question is around self-harming behavior. Do we have any data on self-harming behavior and if it's correlated with acute care utilization or virtual care?
So we do. So we didn't present those data today, but at ICES, our team has been working on looking at trends over time in the both child, adolescent, and adult sectors. And we've seen over time through to the end of December that visits for self-harm are actually lower and visits for severe self-harm are lower. So those who end up in ICU, fortunately, are lower. Whether or not we're going to see a tsunami of need once, kids move through or adolescents move through this third wave, it's hard to know. But with the data we have so far, we've seen a decline, fortunately. Although you wouldn't know it on the wards.
So I'd like to take the last question, and it's just an open-ended question for all of you because these presentations were fantastic and there are other excellent comments in the box. You're on an elevator with a policymaker and you have 15 seconds to give them, a spiel based on the work that you've done. Amazing work on symptoms, on diagnoses, on interventions that all of you have presented today, and on inequities. What would be your pitch given the learnings of what's been going on during the pandemic regarding mental health in children? Let's start with you, Dr. Williams.
Thanks, I would say supporting parents is the #1 way to actually optimize young children's support and get their gaps in service. We need your support. Thank you.
We'll go backwards. Dr. Tulane.
As we've heard in other discussions this week with presentations in the Leong Center, I think partnering with adolescents and the young people themselves is key to understanding what they actually need. So we have our preconceived notions, but we truly don't understand what it's like for them.
Dr. Saunders.
So my recommendation is quite specific to policymakers. I think at the onset of the pandemic, we had an introduction of fee codes that facilitated virtual care delivery that didn't exist before. And we've seen that it's totally restructured how we deliver care. And these were temporary fee codes. So to have these in a more permanent form is going to be important going forward.
Dr. Rizeq.
I'm always been an advocate of early identification and early prevention, making sure we're planning long-term, not just in the next 2 or 3 years, but really thinking in the long run and trying to identify, prevent, and reduce the inequities, because those really are amplified during times of public crises when we're constantly putting out fires rather than preventing them.
And Dr. Cost.
So I've got 15 seconds, I'm gonna go big. So I'm gonna say universal basic income and increased capacity for comprehensive OHIP coverage for mental health for children, but all people, adults, parents, anybody.
And so sorry for putting you all on the spot there. I just thought it would be really important to get that in because at the end of the day, the work that you do is so important in trying to drive improvement. So really appreciate these excellent presentations, this excellent discussion, and the work that you have all done to support knowledge, advocacy, and improvement in outcomes for children and youth. So huge thanks on behalf of the Leong Center, the Center for Brain and Mental Health, and the Department of Psychiatry for everyone who participated today. Have a wonderful day.